Now, after Christmas, we are going to have another program, and you are going to hear from Dr. Mamta George. She is Professor and Head of Department of Dermatology. Now, a brief introduction of Professor. He was, in fact, I didn't know. She, told me that in 2006, he was runner-up of the IADVL quiz competition. Even hope all of you remember the IADVL quiz competition. It was started in 2005, and 2006, the second edition of quiz, and she was the second place winner. So from those days onwards, Dr. Mamta George is very enthusiastic dermatologist, and she had a good career record, and now she is heading the department, and she is a good organizer. That is what I observed during the Cuticon and other things. Apart from the academic, she is a good organizer, and she is a good manager of the department, and a good teacher. So today she is going to tell something about reactions in leprosy. So you may wonder why this topic is. The leprosy is coming down, and is there any need to know leprosy? That is a big question in front of you. So I should say that leprosy is always a problem, and only dermatologists could make a diagnosis clearly of leprosy and the problems of leprosy. And the problems of leprosy, earlier we thought a lot of different problems. Now we have, because of negligence, because of improper treatment, improper diagnosis, there are a lot of complications, especially reactions. And the reactions are missed even by dermatologists. So it is always better to have a good working knowledge of leprosy reactions. Previously, we had the talk on clinical features. Now, we are going to hear from Dr. Mamta George, the reactions in leprosy, clinical features, and treatment to some extent. So, over to you, Dr. Mamta.
Thank you. Respected seniors, dear colleagues and postgraduates, a warm good morning to all of you. At the outset, I thank Crichton sir for this opportunity and for the nice words he spoke about me. It's an honor to be here. I also thank East West Pharma for organizing this webinar. So let's move on to the topic, reactions in leprosy. So let's start with a case. So let's have a look at this case. A 40-year-old female presented with hypopigmented hypoaesthetic plaques involving the trunk and extremities. The right ulnar and right common peroneal nerves were thickened with sensory impairment along the supply of nerves. The slit skin smear came negative, and histopathological features confirmed the diagnosis of Hansen's disease, BT spectrum. The patient was advised MB-MDT, which she took regularly for 1 year. So after 2 months, she presented with sudden onset of erythema and tenderness over the pre-existing lesions, and she noticed few new lesions over the forehead. The constitutional symptoms were absent. The slit skin smear was repeated, which came negative, and the histopathology also, it was done from the same site as previous biopsy, which showed granuloma with intragranular edema and abundance of lymphocytes, which suggests a reaction. So she was diagnosed as late type 1 reaction and was treated with prednisolone 30 milligram, which was gradually tapered, and the lesions completely resolved within a month. So I'd like to acknowledge Dr. Saritha S. for allowing me to present this case. So let's see what reactions are. Reactions are acute inflammatory episodes occurring during the otherwise chronic course of leprosy. So these are basically hypersensitivity reaction to bacillary antigens, and a genomic predisposition has been suggested. So we have type 1 reaction, basically we have type 1 reaction, type 2 reaction, and the Lucio phenomenon, it's called as type 3 reaction. So about type 1 reaction, it's typically seen in borderline patients. Why? Because of immunological instability, and it can rarely occur in lepromatous, that is in subpolar lepromatous leprosy. So it's seen in borderline patients, BT, BB, and BL. So it can occur, this type 1 reaction can be the presenting feature of a disease, or it can occur during the course of disease. It's most commonly seen during the first 6 months of starting MDT. And this has been reported even after completion of treatment, that is called as late reversal reaction. So reaction occurring, type 1 reaction occurring after completion of treatment is late reversal reaction. So 30% of borderline patients experience type 1 reaction at some point during their disease course. So the Patho mechanism involves the antigens released from the lepra bacilli. They interact with the T lymphocytes that is associated with a rapid change in cell-mediated immunity. And remember, the type 1 reaction is an example of type 4 hypersensitivity reaction, that is a delayed hypersensitivity reaction to the antigens released from the lepra bacilli. And this occurs due to a shift in host cell-mediated immunity. So genetic susceptibility is there. So coming to the types of type 1 reaction, we have upgrading type 1 reaction and downgrading type 1 reaction. Upgrading, it is associated with a rapid increase in cell-mediated immunity, whereas downgrading, the reaction is associated with a reduction in immunity. So why upgrading reaction? It is called as reversal reaction because the natural tendency of a borderline patient is to downgrade to a lower spectrum, to a lepromatous form, which is reversed with treatment. That's why the upgrading reaction is called as reversal reaction. This is usually seen following starting MDT. And if there is an increase in cell-mediated immunities, the shift is from borderline spectrum to tuberculoid spectrum. And the BT and BB patients have upgrading reaction usually occurring early, between 2 weeks to 6 months of treatment, whereas in BL patient, it occurs late, usually after 6 months of starting treatment. The upgrading reaction also can occur in subpolar LL, though it is rare. Subpolar LL under treatment, these patients rapidly regain their lost immunity and upgrade to a higher spectrum. Coming to downgrading type 1 reaction, this occurs usually in patients who have not started on treatment. So the shift is towards lepromatous pole with a reduction in immunity. So it is called as downgrading reaction. So downgrading reactions are more frequent than upgrading reaction during the normal course of leprosy, though the natural tendency is to downgrade to a lower spectrum, which is reversed with treatment. Let's see what are the risk factors for type 1 reaction. The borderline group of patients are most vulnerable. Among this, BB is at higher risk than BL and then BT. Though the BT, the reaction occurs early, the risk, the BB patients are more vulnerable to development of reaction. Then patients who have one episode of type 1 reaction is more likely to develop a second reaction. Females are more prone due to the hormonal fluctuations. And pregnancy and delivery can increase the risk. Also, older age group, the risk is more. The other risk factors include multiple and disseminated patches involving large areas. Multiple nerve involvement are at risk of developing RR. Then patients with the facial patches, they are at risk for developing type 1 reaction. Nerve involvement, paresthesia, and tenderness on palpation are also reported to be at increased risk. Then the starting MDT. So this type 1 reaction, usually it is seen within 6 months of starting treatment. Why? The starting treatment may precipitate reaction that is due to increased breakdown products and release of bacterial antigens. So this causes a delayed hypersensitivity reaction. Then intercurrent infection, any form of stress, whether it is physical or mental, can exacerbate type 1 reaction. Then the vaccination, routine vaccination also can predispose to type 1 reaction. And type 1 reaction can occur as a part of IRIS, the immune reconstitution syndrome in HIV patients. So coming to the clinical features of type 1 reaction, the patient usually presents with acute onset of erythema and edema of skin lesions, along with or without neuritis. And the other featuring is edema of hands, face, and feet. So basically, there is in type 1 reaction, especially in reversal reaction, there is inflammation of the skin, inflammation of nerves, and edema of hands, feet, and face. So what happens to the pre-existing skin lesion? The lesions will become more erythematous, more edematous. The lesion will become more prominent, shiny, and warm to touch. So the appearance of new lesions may appear even in reversal reaction or the upgrading reaction also. The patient may develop few new lesions, but not as of downgrading reaction. And when the reaction subsides, the skin becomes dry, scaly, and ultimately it flattens, leaving a wrinkled, hypopigmented surface. So upgrading reaction, as I said, may present with few new lesions, whereas downgrading reactions, you get new lesions and the lesions will be more of atypical clinical presentation, that is more of the lepromatous spectrum. The morphology will be more towards lepromatous spectrum. And edema of hands, face, and feet, that is seen in both upgrading and downgrading reaction. There can be tenderness of palms and soles. And severe reactions may be accompanied by systemic illness, the low-grade fever, malaise, and anorexia. So systemic symptoms or constitutional symptoms may be seen in severe reaction. Another important feature of type 1 reaction is neuritis. So the neuritis can occur with or without skin involvement. So there is rapid swelling or one or more of the nerves with pain and tenderness at the site of swelling. And there is a tinel sign. That is tinel sign when you tap on a nerve, lightly tapping on nerve gives a tingling pain distally. That is called tinel sign that indicates neuritis. And sometimes the loss of nerve function, that motor function, can occur without any signs of skin inflammation. That is called as a silent neuritis, which makes it difficult to diagnose. So the motor weakness without any skin inflammation, that is called as silent neuritis, leading to claw hand, foot drop, or facial palsy. So in severe cases, there can be nerve abscess also. So this is briefly about the differences between an upgrading type 1 reaction and a downgrading type 1 reaction. The onset upgrading reaction usually within first 6 months of starting therapy, whereas downgrading usually seen in patients who are untreated patients or those who are taking interrupted treatment. So there is in upgrading, there is alteration and both alteration and cell-mediated immunity. The CMI is increased in upgrading and it is reduced in downgrading. So features, the inflammation, the signs of inflammation will be more in upgrading reaction. So acute inflammation of the existing lesion, the pre-existing lesions will become erythematous, edematous, tender. Then even severe cases, there can be necrosis and ulceration. And it discomates during healing, and new lesions may appear occasionally. So the signs of inflammation, the inflammation in the skin and inflammation in the nerve, it is more in case of upgrading reaction compared to downgrading reaction. In downgrading reaction, the lesions worsen and morphology will become more of lepromatous and new lesions will appear. And histopathology, there is more of edema in upgrading reaction. The bacillary count will be reduced and increase in number of lymphocytes, epithelioid cells, and giant cells in upgrading reaction. In downgrading reaction, increased bacilli and more of macrophages. The treatment, systemic steroids are required in almost all cases of upgrading reaction. In downgrading reaction, mild downgrading reaction, we can continue with the MDT. And if steroid is needed, most of the time, lower dose is enough. So this is broadly classified as the type 1 reaction, mild reaction and severe reaction, mainly for treatment purpose. So mild reaction, mild erythema and edema of few skin lesions, without neuritis. If there is neuritis, it is considered as a severe reaction. So the severe reaction involvement of more number of lesions, appearance of more inflamed new lesions, neuritis, increasing nerve function impairment, then facial lesions, edema of hands and feet, ulcerative skin lesions, then systemic features, and the reactions persisting for more than 6 weeks with the usual dose of analgesics. You consider reaction as mild and you start on analgesics. If it is not improving, you can consider it as severe and start on systemic steroids. And facial involvement, it is considered as an emergency due to risk of facial palsy. So this is a classification mainly for the treatment purpose. And rare presentations of type 1 reaction include tenosynovitis due to synovial inflammation, which is common in BT and BL. And very severe reaction, there can be development of necrosis and deep ulceration. That is, exaggerated hypersensitive reaction can occur. And sometimes this is referred to as the Lazarine Leprosy. The ulcerative type 1 reaction is sometimes referred to as Lazarine Leprosy. I'll be dealing with this in the latter part of my presentation. This is a diagnostic, though the diagnosis is mostly clinical. Naff et al. Proposed a criteria for diagnosing type 1 reaction. The major criterion include pre-existing skin lesions becoming more inflamed, more edematous, erythematus, or appearance of new skin lesions. And the minor criteria, which this we have already discussed, the tenderness, neuritis, crops of new painless lesions appearing, edema of hands and feet or extremity and face, and neuritis. So these are the minor criteria. So either one major or at least 2 minor criteria is required for diagnosis. There are certain clinical terms in relation to type 1 reaction. Acute type 1 is symptoms persisting up to or less than 1 month. Subacute is when the symptoms persist for up to 6 months, and chronic, the symptoms of type 1 reaction persisting for more than 6 months. And recurrent or repeated, the episodes occurring after 3 months of stopping the reaction treatment. You stop the reaction treatment, and if it recurs after 3 months, it is recurrent. And late reversal reaction. Late reversal reaction is any reversal reaction occurring after completion of MDT, even if it is on the second day. After completion of MDT, if reaction occurs, it is called as late reversal reaction. These are the differential diagnosis for a patient presenting for the first time with a type 1 reaction. And the course of disease, if properly treated, it seldom persists for more than few months, and recurrence indicate inadequate therapy. Coming to management of type 1 reaction, the anti-leprosy MDT should be started if you're seeing the patient for the first time in reaction, MDT should be started, or if the patient is already on MDT, it has to be continued. And specific treatment is based on the severity. Mild reaction usually resolves over weeks and can be managed by NSAIDs. You can give aspirin or paracetamol. And in severe cases, we have already defined what is a severe case. So in those cases, initial dose of 40 to 60 milligram of prednisolone is advised till control. And once there is evidence of improvement, once the inflammation subsides, the dose can be reduced by 5 to 10 milligram every 1 to 2 weeks until a dose of 20 milligram is reached. This 20 milligram is called as a critical dose. That is a critical dose. This dose for effective control of type 1 reaction, this 20 milligram or the critical dose should be maintained for some time. It should not be tapered easily. And this dose should be continued for some months till the nerve function improves. That is called as a critical dose. And slowly we can taper. Once the nerve function improves, you can slowly taper by 5 milligram every 2 weeks. So a total of 3 to 6 months. In BL patients, BL patients may require even longer duration. So there is certain defined protocols. So you start with a 40 to 60 milligram till control, then you reduce by 5 milligram every 1 to 2 weeks till a dose of 20 milligram, that is called as a critical dose. This has to be continued for quite some time till optimal nerve function recovery. Then after that, you can reduce by 5 milligram every 2 weeks, a total duration of 12 to 20 weeks, and the duration depends on the spectrum. In BL patient, we need longer duration. The second protocol is 30 milligram for 2 weeks, then 25, 20, 10, and 5 is the third protocol. So, the mainstay of treatment is systemic steroids. The other immunosuppressives include methotrexate, cyclosporin, which has got an additional action on nerves, also neuritis, associated with a decrease in anti-nerve growth factor antibodies. So this helps in chronic neuritis. Then azathioprine is also tried with good result. The other drugs tried include clofazimine. The use is controversial, though clofazimine is highly effective in type 2 reaction. The role in type 1 is controversial. A high dose of 300 milligram has been tried in occasional patients with a good result. Then apremilast is being tried with good result in type 1 reaction. Another agent is colchicine. And topical steroids are being recommended for localized reactions and mild reactions occurring in pregnancy. Biologicals are also being tried. The TNF-alpha inhibitors like infliximab, interleukin-17 inhibitors, secukinumab, and drugs acting on interleukin-1, anakinra, and other agents, and also tocilizumab, that is anti-interleukin-6 agent, is being tried in type 1 reaction with good result. And another part of management is treatment of neuritis. So in addition to systemic steroids are mainstay for neuritis also. And in addition to systemic steroid, appropriate splinting and paddling is important. And when the acute phase is over, we can advise active and passive exercise. Then oil massage, short wave diathermy, and ultrasonic therapy also helps to restore the nerve function. And surgical decompression of swollen nerves in patients with persistent nerve pain despite. So the patient is not responding to systemic steroids, then surgical decompression may be advised. Follow-up patient, record all the episodes of reaction, including the clinical features, all features of reaction, clinical features, severity and duration, and the details of nerve function impairment should be recorded. Also the details of the treatment given, the dose and duration of steroids given, and the patient should be ideally reviewed every 2 weeks while on systemic steroids. And once the steroids are stopped, the patient can be seen monthly initially and then once in 3 months. And about late reversal reaction, our patient had late reversal reaction. So sometimes there may be situations where it is difficult to differentiate relapse from late reversal reaction. So late reversal reaction, the definition is reaction occurring any time after completion of MDT. And usually late reactions occur within first 3 years of treatment. And what is relapse? Relapse is when a patient successfully completed adequate course of MDT. When a patient who has successfully completed adequate course of MDT, presenting with new signs and symptoms, occurs mostly after 3 years, whereas the late reversal reaction usually we see within the first 3 years of completion of MDT. Here, this relapse is seen after 3 years of completion, and this can be delayed up to 7 to 10 years. And the skin lesions, usually there is no edema, no tenderness, and new lesions are common in relapse. So nerve involvement, there is gradual onset without neuritis, whereas neuritis is an important feature in type 1 reaction. Here, the nerve involvement, there is gradual involvement of nerves, and it is usually often limited to few nerves, whereas in reaction, multiple nerves will be involved, and there will be inflammation, signs of inflammation in nerves. And a log2 rise in BI or MI above a log2 rise in BI or MI above 0, that is highly suggestive of relapse. So this is how you differentiate late reversal reaction from relapse. And late reversal reaction, to differentiate when late reversal reaction from relapse, bacterioscopy or the presence of solid staining form is the only means to differentiate a late reversal reaction from relapse. So in rare instances, when it is difficult to differentiate a late reversal reaction from relapse, a therapeutic trial of corticosteroid is being recommended by WHO. So complete subsidence, we are giving systemic steroid and complete subsidence within 2 months. That indicates late reversal reaction, whereas partial improvement or persistence of lesion, more suggestive of relapse. And if the reactive skin and nerve lesions, in reaction, the skin and nerve lesions do not show improvement within 3 months of steroid therapy, the case should be considered as relapse. So in reaction, we are treating with systemic steroids and there is not much of improvement within 3 months of steroid therapy. The patient, this can be considered as a relapse, presenting in the form of type 1 reaction, and MDT should be restarted for another course, and the oral steroids can be gradually tapered. This is a WHO recommendation. So that's about type 1 reaction. Now coming to type 2 reaction, it is also called as Erythema nodosum leprosum. So it is exclusively seen in patients of multibacillary leprosy, mainly in LL and BL patients with a high bacillary load. So the incidence of type 2 reaction in pre-sulfone era was 50% in LL and 15% in BL. With MDT, this has been reduced to 15% and 5% respectively. So what happens in type 2 reaction is immune complex. Basically, it's an immune complex syndrome causing inflammation of skin, nerves, and other organs as well. So there is antigen antibody reaction involving complement. So IgG, IgM, and C3 complement react with a mycobacterial antigen that forms an immune complex involving complement. So this is an example of type 3 hypersensitivity reaction. Genetic predisposition is being mentioned in type 2 reaction also. So remember, type 1 is an example of type 4 hypersensitivity, whereas type 2, it is an example of type 3 hypersensitivity reaction. And this type 2 reaction or the ENL occurs commonly around 6 months after starting MDT. So type 1 reaction mostly we see within 6 months of starting MDT, whereas this is after 6 months of starting MDT, although the patient may present for the first time the ENL lesions. And ENL with other symptoms, that is called as type 2 reaction. So ENL is only the skin manifestation of type 2 reaction. And most of the patients experience multiple acute episodes, and this may progress to chronic ENL, which lasts for more than 6 months. Even this can persist for years. The risk factors for type 2 reaction include lepromatous leprosy with the skin infiltration. The relative risk is 3.6. That is, the patient is at 3.6 times more risk of developing type 2 reaction. Then a bacteriological index of more than 4 as a risk factor, and a BI of more than 6. The relative risk is 8.6. Patients with age less than 40 years. Type 1 reaction is more seen in elderly, whereas this here, the younger age group is more predisposed, and more than 5 nerve involvement, intercurrent infections, trauma, surgical interventions. Any form of stress can precipitate type 2 reaction also. And a strong positive Mantoux is being mentioned as a risk factor for type 2 reaction. Pregnancy, lactation, vaccination, then injection of potassium iodide, intake of potassium iodide, and MDT drugs are being mentioned as risk, except clofazimine, which is given for treatment purpose. Then immunosuppressive state. The clinical manifestations, 20% of patients may present for the first time with type 2 reaction, and 17% within 6 months, and around 50% of patients can present a year after completion of MDT. The different modes of onset are there. The patient may present only with skin lesions, appearance of crops of lesions before constitutional symptom, that is called as a cutaneous onset. Then there is rheumatic onset, where the patient presents with the joint symptoms. And mixed onset is patient will be having skin symptoms as well as joint symptoms. The cutaneous lesions, the skin lesions, they present as crops of lesions, sudden appearance of painful tender crops of erythematous to rose evanescent lesion. Usually the lesion subsides in 3 to 4 days, and they are partially blanchable, warm to touch, and warm and tender to touch. So multiple erythematous, evanescent papules, plaques, and nodules of variable size appear, or usually symmetrical. And the usual sites include the arms, thighs, face. Bumps and soles are not common. Mostly it is seen on thighs, arms, and face. And it can involve any area except the hairy scalp, the axilla, groin, and perineum, the warmer areas, which are usually spared in leprosy as well. And ENL lesion, the ENL lesion fades in 3 to 4 days with PIH and desquamation. And the patient gets recurrent crops of lesions. The crops of lesion mostly they develop in the evening. Why? Because that time the endogenous cortisol production is less. So most of the crops of lesion, mostly the patient will develop during evening hours. And in severe reaction, the lesion may become pustular, ulcerated, hemorrhagic, necrotic, vesicular, or bullous EM-like presentation is also being reported. In case of recurrent lesions, the lesions are not completely resolving, there's a risk for fibrosis. The systemic features, the two characteristic features of ENL include, or type 2 reaction, I should say type 2 reaction include the iridocyclitis, that is ocular involvement is very characteristic, and other is acute epidermoorchitis. These two are the most important systemic features, which systemic involvement which we see in a type 2 reaction. Iridocyclitis and epidermoorchitis. So epidermoorchitis, the patient presents with acute pain, tenderness, and swelling of the scrotum, and repeated attacks can cause atrophy and later leading to gynecomastia. The other systemic features, apart from iridocyclitis and epidermoorchitis, there can be systemic features like fever, myalgia, edema of the hands, face, and feet, and the pain as a common symptom reported by the patient. It can be the tenderness on the skin, or it can be nerve and joint pain. And inflammatory edema of the hands and feet associated with the subcutaneous nodule, that is called as a reaction hand. So there is involvement of the joints of the hand, and in addition there will be erythematous tender nodules on the hand, that is called as a reaction hand. The neuritis is less common compared to type 1 reaction and is often mild. The nerve damage can occur, but not as quickly as it occurs in type 1 reaction. Then bone changes, osteoperiostitis, particularly anterior aspect of tibia, and severe bone pain and soft tender swellings on the anterior aspect of tibia can occur. Then osteoporosis also is being reported. Then there can be generalized lymphadenopathy, acute glomerulonephritis due to immune complex deposition in the kidneys. Then hepatosplenomegaly can occur, and repeated type 2 reaction can lead to amyloidosis. So unusual patterns of ENL, atypical bullous lesions in an annular pattern is being reported in a pregnant lady after injection of ofloxacin. And type 2 reaction can occur without ENL also, only the constitutional symptoms and joint pain. These are the unusual presentations of type 2 reaction. So here you can see the crops of erythematous nodular lesions, and this is called as a necrotic ENL, ulcerating type of ENL, or the necrotic ENL. These are the two clinical tests which we do in a patient with a type 2 reaction. The Ryries test, that is stroking the sole of the foot with the back of a reflexor hammer, elicits burning pain. And also the patient may complain of difficulty in walking, as if the patient will feel as if he's walking on hot coals. And Ellis test is squeezing the wrist elicit a painful reaction. These two are the clinical tests which we elicit in type 2 reaction. Then histopathology, there is dense infiltration of superficial and deep dermis with a neutrophil. So neutrophilic infiltration is the most important feature in type 2 reaction, and superimposed on a background of macrophage granuloma, because it's usually seen in BLL NL patients. So on a background of macrophage granuloma, you see neutrophilic infiltrate, and vasculitis is also a prominent feature in type 2 reaction. This has certain terms in relation to ENL. Acute ENL, a single episode lasting less than 24 weeks while on treatment with corticosteroid. Chronic is occurring for 24 weeks or more. And the recurrent ENL is patient experiences second or the subsequent episode after 28 days of stopping the treatment for ENL. So chronic is the patient gets a second episode within 28 days, and recurrent is after 28 days. So type 2 reaction also is classified as mild and severe. Mild is a few skin lesions, and there can be mild edema of extremities. That is mild type 2 reaction. And severe, ulceration, multiple lesions, ulceration, presence of constitutional symptoms, neuritis, the epidermoorchitis, and all the other systemic features. If systemic features are present, it's considered as type 2 reaction. And response to oral steroids, if the patient in mild reaction, usually it responds to oral steroids within 6 weeks. And in severe reaction, it persists for longer time. The diagnostic criteria for type 2 reaction, similar to type 1 reaction, NAF's criteria for type 2. So the major criteria is sudden eruption of tender papules, nodules, or plaques, which may ulcerate. And the minor criteria include mild fever, enlarged tender nerves, increased loss of the neurological symptoms, arthritis, and all other systemic symptoms. They come under minor criteria, and at least 3 minor criteria should be either 1 major criterion or 3 minor criteria should be there to diagnose ENL. The differential diagnosis, erythema nodosum, of course, we know the cause is different. Then rheumatic fever, connective tissue diseases, then drug reactions and panniculitis, all these comes under differential diagnosis for erythema nodosum leprosum. Coming to management of type 2 reaction, the main aim of treatment is to control systemic inflammation and to treat neuritis. So general measures, all patients should be counseled regarding the nature of disease, because type 2 reaction, the patient is prone to develop recurrence. So we should advise regarding the, counsel the patient regarding the natural cause of disease, and patient should be advised rest. And all attempts should be made to find the trigger. If there is any triggering factor, we have to treat that also. We have to treat the triggering factor also. And treatment based on the severity. So mild cases, we can start with treat with NSAIDs. So we have to continue, or if the patient is not on MDT, we have to start MDT and treat the precipitating factors. So mild cases, we can manage with the analgesic and also colchicine, which inhibits a neutrophil chemotaxis. So colchicine is being tried in type 2, mild type 2 reaction with good result. So there are certain definite indications for, broadly it is mild cases we can manage with the analgesics, whereas severe cases we need to start systemic steroids. But these are the definite indications where we have to start the patient on systemic steroids in type 2 reaction. Neuritis with the impending nerve palsy, iridocyclitis, epidermoorchitis, and necrotic ENL. So these 4 situations we have to definitely start on systemic steroids. So in severe type 2 reaction, corticosteroids and thalidomide, these are the mainstay of treatment. So WHO recommends prednisolone at a dose of 1 milligram per kilogram per day for first 2 to 4 weeks, tapered every 2 weeks by 10 milligram till 20 milligram per day is reached. So you start with 40 to 60 milligram, taper by 10 milligram every 2 weeks till 20 milligram is reached. Then from there on, you taper by 5 milligram every 2 weeks. Another recommendation is combination of prednisolone with clofazimine. So along with prednisolone, we start clofazimine in a dose of 100 milligram TID for first 1 month. Then it can be extended up to 2 months also. Then you taper as 100 milligram BD for another 1 to 2 months. Then 100 milligram TID for another 1 to 2 months. And the total duration of clofazimine should not exceed 12 months. So initial 1 to 2 months, you can start with 100 milligram TID, then 100 BD, and then 100 TID. Then thalidomide is another agent which is which is highly effective for type 2, severe type 2 reaction. The mechanism of action you will be familiar with. The dose is 200 milligram BD. Usually we start with 100 milligram TID or 200 milligram BD for 1 week, and then gradually taper over a period of 3 to 4 months. So 100 milligram, initially start with the 200 BD, then you can make it 100 in the morning and 200 in the evening. So 300 milligram for another 4 weeks, then 200 and then 100, and then 50 milligram daily in the evening or 100 milligram on alternate days. So this is a recommendation. So prednisolone with clofazimine This we have already discussed. As you start with a 1 milligram per kilogram of prednisolone. Along with that, you start with clofazimine 100 milligram TID. Another regimen is thalidomide and prednisolone. This you all might be familiar with. Next agent is so clofazimine we already discussed. Then pendoxifylline in a dose of 400 milligram 3 to 4 times daily and gradually taper over a period of 3 to 6 months. Minocycline is the second-line anti-leprosy drug, which is also found to be effective in controlling type 2 reaction, 100 milligram OD for 3 months. Then apremilast is also tried in type 2 reaction. It's a phosphodiesterase 4 inhibitor. Then the other treatments being mentioned are plasma exchange, which removes the antigen antibody complex. Then leukotriene inhibitors are also being tried. Then thalidomide derivatives like lenalidomide and supidimide. That is a newer one which is being tried in type 2 reaction. Then the steroid-sparing agents which are tried in type 2 reaction are azathioprine, methotrexate, cyclosporine, and mycophenolate mofetil. Then the biological TNF-alpha inhibitors like infliximab also being tried with a good result. Then treatment of other complications, motor deficit, we have to do splinting, physiotherapy, surgical correction if required, acute iridocyclitis, topical and oral systemic steroids. Then atropine eye drops can be advised. And epididymoorchitis, systemic steroids, in addition to that, bed rest and scrotal support. Coming to type 3 reaction or Lucio phenomenon. Lucio phenomenon is called as type 3 reaction. It is it's a special type of reaction which is observed in Lucio leprosy patients. So what is Lucio leprosy? Lucio leprosy, also called as Lucio leprosy. It was first described by Lucio and Alvarado and later by Letapy and Zamora. So it is called as Lucio leprosy. It is characterized by diffuse non-nodular infiltration. So there are no nodules. So diffuse, shiny, non-nodular infiltration of skin. It's considered as a type of lepromatous leprosy. It is chiefly encountered in Mexico. There are reports, isolated reports from India also. And Lucio phenomenon is seen in Lucio leprosy patients. Usually it occurs 3 to 4 years after the onset of disease. And it is mostly seen in untreated cases. Some consider this Lucio phenomenon as a subtype of necrotic ENL. And a word about Mycobacterium lepromatosis. This is a second causative agent of leprosy. This was discovered in the year 2008, and it is found to be associated with the Lucio leprosy and Lucio phenomenon initially, but now it's being found in other forms of leprosy also, like BL and BT. And using sequencing of 16S ribosomal RNA distinguishes M. leprae from M. lepromatosis. So this sequencing is used to distinguish M. lepromatosis from M. leprae. The clinical manifestations of Lucio phenomenon. Lucio phenomenon is seen in Lucio leprosy patients. So the patient will be having diffuse infiltrated skin, and on that you see red bluish patches which are tender to touch and with an erythematous halo and commonly seen on limbs. And after a few days, the lesion, the center will become purpuric and later a hemorrhagic infarct develop there can be blister formation in severe cases. And the characteristic margin is called as a jagged margin or angulated margin or triangular margin. The ulcers, the margin of the ulcers is called as the ulcers with a jagged margin is characteristic of Lucio phenomenon. This is here you can see a reddish macule and later developing into developing necrosis. So this is the patient had developed, it's a severe type of Lucio phenomenon where the patient developed bullous lesions. And usually the patient will have lesions at different stages of evolution. And here, in compared to type 2 reaction, necrotic AML, the patient will be febrile. Systemic features will be there, whereas in Lucio phenomenon, the patients remain afebrile throughout. That's minimal systemic features and neuritis. Neuritis is absent in Lucio Phenomenon. So this is in contrast to ENL. The histopathology shows epidermal necrosis, vasculitis of small blood. There can be fibrin can be seen, and the important feature in Lucio Leprosy is large bacilli within the endothelial cells. The endothelial cells will be infiltrated by the bacilli. So that is a characteristic histopathological feature in Lucio Leprosy. Treatment is the condition improves with MDT. After starting MDT, the condition improves and the patient responds very well to oral steroids. And in contrast, unlike in ENL, thalidomide usually shows no result. Thalidomide is not being effective in Lucio Phenomenon. So these are the differences. This is how you differentiate the systemic features. Usually systemic features are absent in Lucio Phenomenon. And the histopathology also, you see endothelial cell being infiltrated by bacilli, and you see the vasculitis. Vasculitis can be there in ENL also, but it's more in Lucio Phenomenon. And thalidomide usually will not help in Lucio Phenomenon. And finally, about Lazarine Leprosy. Lazarine Leprosy, it's being mentioned in some articles mentioned Lazarine Leprosy as a ulcerative type 1 reaction borderline spectrum. It's also considered as a synonym for Lucio Leprosy. But this is an article which is published in IGDVL by Ashokan sir. And he concluded that he had reviewed the literature about Lazarine leprosy and concluded that Lazarine leprosy, the term should be used to describe rare instances of spontaneous ulceration in leprosy associated with malnutrition. So any type of leprosy with ulceration in a background of malnutrition, it should be called as Lazarine leprosy. So we have come to the end of this webinar.
Thank you, Dr. Mamta, for your excellent talk. And while hearing a lot of concepts which you have clearly elaborated and driving, so all the postgraduates will be benefited with that. And postgraduate, please read the topic once again, and then you will be having a thorough understanding of what Dr. Mamta just talked. And wishing you all the best. Thank you.
Thank you, Doctor. So Eastwest Pharma extend our gratitude to the speaker, Dr. Mamta George Madam, has delivered an excellent lecture to our benefit of the pages. It will be Lucy and a benefit for all our pages. And also, we are extending our gratitude to Dr. Kaitan sir, has continuously past 2.5 years conducting the programs with reputed speakers across the country. So the recorded version is available with our Eastwest Pharma people, and also Eastwest Pharma congrats all the winners, those who participated in the quiz program. The certificates and the gift vouchers will be received to you in your hand via our field force. And any other things, kindly for the recording versions, you just contact our Eastwest Pharma field people. So Eastwest Pharma always committed for the academic versions. So the speakers will be continued. The topics, new topics will also be continued forever. And from Eastwest Pharma, we are delivering. Wish you Happy New Year to all.
Thank you.
Thank you, ma'am. Thank you, sir.